How do you define the hip? As pelvic floor therapists, addressing all aspects of the hip is imperative to achieve good outcomes with your clients. Listen in to today's speaker, physical therapist Carrie Hall, as we discuss the impact of the hip on the pelvic floor and why we should be considering the entire structure of the hip, which includes the acetabulum and position of the pelvis.
Hello, friends. This is Lynn Schulte, and you are listening to the Birth Healing Summit podcast. We are here for meaningful conversations that will transform the way you work with pregnant and postpartum clients. Whether it is a new perspective, tool, or technique, you'll be able to implement it into your practice today. I invite you to sit back, listen with an open mind, and grab the golden nugget today's guest has to offer. Now let's get started. I have an amazing guest to share with you today. I'm really excited to do this interview with Carrie Hall. Carrie is a physical therapist in Seattle, Washington. She's a former practice owner. She just sold her practice. Congratulations on that. Carrie has been an educator at the university level and also has done a ton of continuing education in movement system related topics. She has 4 editions of her textbook, Therapeutic Exercise, Moving Towards Function. Welcome to the podcast, Carrie. Thanks so much for being here.
Happy to be here.
So, Carrie, another big thing that you have done throughout your career is you actually have been mentoring with Shirley Sahrmann. Tell us about that. How long have you been doing that, or how did that even develop?
Yeah, thanks for asking. Well, it was right place, right time. My very first job out of PT school was in St. Louis, and it was at the Irene Walter Johnson Rehabilitation Institute, which was part of Washington University. And I was hired not only to be a practitioner, but also to be considered clinical faculty at Washington University in St. Louis, which is how I met Dr. Shirley Sahrmann, the legendary.
Yeah.
And at that time, that was in 1983. And at that time, Shirley was developing her course, her continuing ed course through her theories and philosophies on, at that time, it was diagnosis and treatment of, I think it was muscle imbalances or something along that line.
Yeah.
And it's evolved over time to diagnosis and treatment of movement system impairment syndromes. And so at that time, of course, I was a sponge. I was a brand new professional and eager to learn. And who better to learn from than Shirley Sahrmann herself? So whenever I had any free spare moments, I asked if I could shadow and just absorb everything. And what I noticed working with Shirley is that she went from like synapse A to synapse Z in a nanosecond, and I was still at synapse B. So I asked a lot of questions, probably annoyingly so.
Yeah.
But I think she really enjoyed the curiosity.
Oh, that's great. Did you go to WashU, or are you originally from St. Louis, or?
No, I went to St. Louis University for undergraduate, but I did go to Washington University for graduate school.
Oh, you did?
At that time, as you know, Lynn, in 1983, there was no DPT. It was a Master's of Health Sciences. So that was my postgraduate degree.
I started my PT career in '86 at SLU.
Oh,
I know,
okay, well,
right?
I know a lot of the same people. Yeah.
Was Rob one of your instructors? Do you remember Rob and Cheryl and
Cheryl? Yes.
Cheryl? Yeah. Oh my gosh.
Yeah.
Rob might have been new at my stage, but have you been down there recently to see the amazing changes that they have made to that campus?
Yeah, so 2 of my daughters toured the campus when they were looking at colleges.
Yeah.
So yeah, it's gorgeous.
Oh my gosh.
I'm just like, well, we didn't have beach volleyball when I went there. So
Right? Oh my gosh. Remember taking the red bus down to the
yeah.
Oh my goodness. So I had no idea. I didn't know you went to St. Louis University. So that's amazing. Okay. So now you're in WashU and you're working with Shirley Sahrmann and you're getting to see her in action and you're getting to ask her all these questions. What was like your biggest takeaway in watching her work?
Well, at that time, there was a big emphasis in kind of the ortho movement, and it was the kind of more of the Maitland type of approach, which was really strongly taught at SLU, as you know.
Yes.
And Shirley is not a manual therapist. She doesn't have an ortho background. Her background is all in neurology.
Oh,
And so
really?
her PhD is actually in neuroscience. And so the way she looked at patients was so different because she was really looking at their movement the way more of a neurotherapist would, but applying it to musculoskeletal populations. And so it was the quality of movement and the motor control that she was applying to musculoskeletal patients, which today seems obvious, but in 1983, that was completely kind of mind-blowing. And but also very obvious. You're like, well, yeah, of course they have nervous systems too, you know. And so I think that was the biggest part of it, was how she kind of, at that time she was really pulling in, you know, sort of the neurological components and the musculoskeletal components into the movement system, involving other systems of the body as well, physiologic systems of the body.
Yeah.
You know, and her theories became very popular. She was starting to teach them. She called them her roadshow, and she needed people to help her teach. And she asked me if I'd be one of those people.
Yeah.
So, of course, you know, when Shirley says, you know, asks you to do something, you just say yes.
Oh,
And so, yeah, and that started my continuing education career. I'd already been teaching at the university because that was part of my job.
what did you teach there, Carrie?
Well, that's a funny story too, because when I was hired, you know, for all you PTs out there, imagine yourself as a brand new PT and you are asked to teach at a prestigious university such as Washington University. And you're thinking, okay, they're going to ask me to do something like positioning, turning, and draping, or, you know, something like that, wheelchair transfers, you know, something like that.
Yeah.
No, my first assignment was shoulder kinesiology. That's it.
Oh my goodness.
And so that, you know, was quite an overwhelming task. I took it over from Dr. Steve Rose, who's also legendary. And he did, you know, give me a little bit of a jump start with his notes, but, you know, I had to really create it on my own. And again, 1983,
Yeah.
there was no PowerPoint.
There's no internet.
There's no internet, no PowerPoint. These were, you know, the slides in the carousel, one, you know, click one at a time, and talk about it. And so that's what I started with. And you know, I've taught on myriads of topics, you know, over the years at Washington University, Northwestern, University of Washington. And, you know, education is at the kind of it's my foundation, not only that as part of my career, but how I approach patient care. It's the fundamental is in education and empowering patients through knowledge. So,
I'm curious because I'm going back to you having to do your shoulder. Your first course is on the shoulder.
yeah.
I still remember to this day the Shirley Sahrmann exercises up against the wall, you know, the
Yes.
progression of all that. Did you have Shirley to kind of help you, or were you on your own? Had she
Well,
developed that at that stage, I guess?
yeah, I mean, I was teaching just the basic, you know, kinesiology at that point. So it wasn't really
Okay.
jumping into the exercises, but I
Exercise.
will
Got it.
comment on that, that if you're a PT and you go to a file cabinet, again, 1983,
Yeah.
and you see these exercises all in these folders, they're very simple. You know, it can be just knee to chest. It can be a forward bend. It can be, you know, as you said, it can be like a prone, you know, kind of lower trap exercise. Nothing seems overly complicated. And I was like, well, what's the big deal? These are just movements, but it's how you apply it to that individual and their movement system and all the nuances is
Yeah.
what makes it complicated. And you turn that simple exercise into a custom pattern for that particular patient that you are treating. So it's not so simple. And so that's why I struggle even today with using online home exercise program platforms, because how I teach it is nuanced to that specific person.
Sure.
So
And so we need to be looking at all the different ways in which they're moving and the compensations that patients are bringing to that movement, to that pattern, to to make the tweaks,
correct.
help them to do something different and see if that affects their pain, their function, all that.
Yes, exactly.
And
So there's a repertoire, you when you're just building the foundation for somebody's movement system, there's a limited repertoire of exercises and movements, but how you prescribe those
Mhm.
are customized to that individual and that particular snapshot in time, because that evolves, with that individual as their movement system changes.
Yeah. Carrie, I'm curious, when you were working with Shirley, were you over time able to see what she saw? Or, like I'm imagining at the very beginning, and she's seeing someone do this movement, right? Were you seeing the same things, or did she help point out the movement and what was kind of, I don't want to say wrong or abnormal, or just maybe different? Were
Hmm.
you able to see that, or was in watching her observe and work with someone, then you started to see it?
It takes time. It takes
Okay.
time to develop that eye. I think physical therapists have the unique education and background to be able to not only see the movement, but also start to think about and hypothesize what's underlying that movement pattern. But it does take time. And I will say that, I mean, I've actually still see Shirley work not on a daily basis, but I see her once a year, at least, and see her work. And she's well into her late 80s, and I still learn something from her. So,
Wow.
as I hope people, would learn from watching me over time, but the movement system is incredibly complicated. It's hard to simplify it. And I was just so grateful every day, that I was able to meet Shirley, work with her, and have her help to shape the foundation, kind of the lens through which I, look at my patients, in their function, in their what they're doing on a daily basis.
Right. That's just got to be so amazing. I was wondering if Shirley was still alive, so she's still
Oh
with
yeah.
us
Oh,
and still
she
working.
is not only alive, she's like the Energizer Bunny. She has more energy than you and I put together. She's
Oh,
an amazing human being, and
wow.
still just brilliant genius of an individual. And our profession is so much better off for her.
That's awesome. So you did all this training with Shirley, but then you kind of developed your own thing. How does what you've developed different from what you learned from Shirley, or how did you put your own spin on things?
Well, I think, again, coming from SLU, I did have a strong manual therapy background. We learned, as you remember, using the Maitland approach, really the arthrokinematics of every joint down to the DIP of the fifth digit. I mean, we learned all that. So I did incorporate manual therapy more so than Shirley, because she's not a manual therapist. So
Oh, okay.
she does what we always used to joke with her. She does mobilization with movement. Um,
Yeah.
and so I didn't still to this day, incorporate manual therapy. And then I also, as pain science has evolved, have been incorporating, more concepts with a biopsychosocial approach toward pain and persistent pain. So I've put a tremendous amount of time and energy into developing my understanding of pain science, not only in my writing, in my teaching, and in my practice.
Okay. Cool. How has that shaped things for you? What you're learning with pain science?
Oh, I mean, it's a blessing and a curse at the same time, right? Because it adds a whole nother layer of complexity. It was much easier when you just thought there was a cause and effect that was very simple,
Okay.
and it's not. But in the same time, it's enriching, because you recognize that your relationship with the patient and understanding what's going on in their life at any given moment in time, particularly as it relates to the psychosocial, spiritual component of pain, is so enriching. That ability to develop that level of relationship with your patient, and be able to. We're not mental health specialists, so that's a disclaimer.
Right.
But for us to understand that those are components that are contributing to their pain experience is very, very powerful, and has to be recognized and has to be called out. And so, as you and I talk, Lynn, this is we're going to be talking very much about anatomy and kinesiology and movement, but this is only one small part of the person's pain experience.
Right. Right. Yeah. And like you said, it could be something from childhood that's being held in that tissue and affecting that movement pattern. And there's so much, the body's so complicated. And that's the other thing that Carrie and I had a challenge with in really trying to pinpoint, what are we going to discuss? What are we going to talk about in this interview? Because everything is so interrelated and connected. And, how do we really kind of isolate it down to one little topic? And so, Carrie, I do want us to talk about where the title of this podcast is Why the Hip? And I want to ask you, why should we be addressing the hip when we're working with our clients that have pelvic floor dysfunction? So why is that?
Probably the most simple answer is that the hip is part of the pelvis. Um, and
Right.
so we'll just start right there. And
Yeah.
I think that it sometimes does get forgotten, because I think it's sort of like the blind men and the elephant, that if you're coming into a situation and you're a pelvic health therapist, you might be thinking that this person's pain generator is coming from something that is pelvic floor or reproductive organ, or urogenital, urogynecologic related. But there also can be overlapping components coming from the hip or the lumbopelvic region. So we can't forget the lumbar spine. And also could be the pain generator, and it might not at all be anything related to pelvic floor or the gynecologic, reproductive organs and so forth. So the hip needs to be considered as part of the pelvis, which the pelvic floor is part of.
Right. Right. And so with the hip, I mean, I kind of, I have I don't want to say, let's see, how do I want to say this nicely? I have a little soapbox that is very important to me, and that is that I teach that we should never do intravaginal work unless we've actually worked externally on the body prior. So, the pelvis is the housing unit of those pelvic floor muscles. And if we're not addressing the pelvic bones prior to doing intravaginal work, I think we're missing a huge piece of the puzzle. And so what drives me crazy is when I have clients coming to me and they've seen a pelvic floor PT and all they've done is intravaginal work. And it's like, the muscles a lot of times are just at the effect of the bones. And, I think that what we're trying to say here is there's a bigger system, that
Yes.
everything's so connected. And I really appreciate you bringing in this new awareness of like, yes, the hip is a big component of it. Because we know the obturator and the piriformis are all very intimately connected, and the deep hip rotators, it's all a part of that pelvic floor. So
Yes.
we need to, so what would you say to a pelvic floor PT about the hip? Like, what should we really be looking at or for, or how can we, I guess, incorporate the hip into, if we're not already? Hopefully we are, but if we're not, what should we be doing or looking for, Carrie?
Yes, I think the first the first place is just considering, well, what is the hip?
Okay, let's start
Okay.
there.
It's really funny, when I'm teaching Con Ed, sometimes I'll have everybody stand up and I go, okay, now everybody put your hands on your hips. And I would say that the vast majority put their hands on their iliac crests.
Yes, yes,
I'm
yes.
like, well, okay, let's start here. That is not your hip, that is your pelvis. So what is the hip? The hip is the acetabulum and the femur. So the femoral acetabular joint,
Yes,
right?
right, right.
And so I think a lot of times when people think about the hip, they either put their hands on the iliac crest, which is not the hip, or they think about the femur.
Yes,
And it's both, it's both the pelvis and the femur. And so we need to make sure that we're considering the orientation of both, three-dimensionally as they interact in a variety of different movement patterns that, we can think, sagittal, transverse, frontal plane. And we know that, all of, both the pelvis and the femur move in all three planes. And so that's where the complexity starts to build.
yeah,
But as you said, the hip, the femoral acetabular joint, does involve musculature that going from the deepest musculature to the most superficial. And the piriformis and the obturator internus are two of those muscles of the hip that are considered external rotators. We'll generally say that about the piriformis. We know it changes its moment arm as you go deeper into hip flexion, but they are hip rotators. Let's just put it that way.
okay.
So you can't be thinking about the pelvic floor separate from the hip because they have shared musculature. That'd be like talking about, the humerus without the scapula, or the scapula without the thoracic and cervical spine. I mean, they all share musculature.
Good. It's all connected.
Yes.
Okay. So what if we were to, because we all need to, like, I think one of the biggest ahas, in you and I just discussing here is that in my knowledge now, it's funny you say, well, we learned all those mobilizations at SLU, and I'm like, did we? I don't remember what, like it's been 30 plus years since we've been there. But I don't remember learning much about the ability for us to change the acetabulum. Like when I think about the hip, I think that my main focus is on that femur,
Femur. Uh-huh.
right?
Yeah.
And so, but now, I work with the pelvis and the iliac crests and their, in flare, out flares, anterior, posterior rotations. And I guess it just never really till I had that light bulb moment of like, oh my God, I'm totally adjusting the angle of that acetabulum.
Right.
I do that.
Right.
But that just wasn't in my awareness back then.
Right.
So
And the acetabulum sits across all three planes. So it's not sitting in the sagittal plane. It's not sitting in the frontal plane. It's not sitting in the transverse plane. It's sitting across all three planes. And we can get into the weeds because you can think about the pelvis as a unit, the total pelvis. I'm not sure if this is being videoed, but my hands
yes,
are
it
up
is.
there trying to
Yes,
be a
it is.
pelvis.
Yeah.
And so you can have the pelvic, rotation, anterior, posterior pelvic tilt, lateral pelvic tilt, and then you can have intrapelvic motions that are working usually kind of opposite to each other. And then you can have that transposed on top of total pelvic motions. So you can see how it starts to get complicated. But at the end of the day, you've got this orientation of the acetabulum that is interacting with the femur. And the femur typically wants to follow the acetabulum, not always, because we can force ourselves into movement patterns that don't follow the acetabulum, which can be looked at and thought of as impingement problems. And yet it's really, impingement is a very loaded term, especially, in orthopedic circles, because impingement means like a bone that's not right, and that there's usually a surgical solution. And you can have functional impingements, which is what the PT needs to identify and be able to treat. So going back to the acetabulum, I can just give an example, Lynn. So
Perfect.
a typical test that we might perform of a patient would just be supine hip flexion. Okay. And so the patient can do it actively. They can bring their knee to the chest, pull it in. You ask them, how does that feel? They might say, ouch, oh, that hurts. So you're like, okay, did I observe something during that active movement that seemed like that could be contributing? So when they brought their knee to their chest, they bring it into more of a kind of more toward midline, as opposed to straight sagittal, or maybe more, away from midline. I take it even one step backward and observe the position of their pelvis just to begin with. So maybe when they laid down, their pelvis was rotated to the right. Okay.
Yeah.
And I'm having them do knee to chest on the left. If they didn't bring that femur into more adduction and internal rotation, if they kept it sagittal, that could be a pinchy feeling.
Right.
You're not following the acetabulum.
Right.
I might say, okay, that hurt you. Let's get your pelvis back to neutral. Now do that again. Oh, that doesn't hurt as much. Bingo. Okay. Now we know that particular positioning of your pelvis was the contributing factor, and you don't have FAI.
Right. And
right?
FAI being, just define that.
Femoral acetabular impingement. That can be cam or pincer. Whole nother can of worms.
Right.
But, then if I'm moving them passively, I can also do the same thing. I can move them passively and gently, move them into a pattern that can be provocative, or I can move them into a pattern that's less painful, knowing the relationship between the acetabulum and the femur. So if and again, we can get into the weeds on, well, that's a rotation of the pelvis. Maybe they were in an anterior tilt. Maybe they were in a posterior tilt. Maybe they're in a lateral tilt. Maybe they were in an pelvic obliquity with one. By the way, I don't talk about pelvic obliquities as an anterior posterior tilt, because it's not on the sagittal plane.
Okay.
So an anterior tilt nomenclature is really flexion, abduction, and external rotation.
Okay.
Tri-planar.
Okay.
And posterior tilt is really extension, adduction, and internal rotation.
All right. So it's not on that frontal plane like we think it is. It's more 3D.
It's more 3D, right? So
Yeah.
the pelvis moves, kind of across those three planes, and what we're getting into minor, because interpelvic torsions are minor, but they make a difference. And for the PTs who have manual therapy background or muscle, osteopathic backgrounds, it can perform a muscle energy technique and make a correction on a pelvic obliquity. You can use that as your modifying test. So the patient brings their knee to chest, it hurts. You've determined that there's a pelvic obliquity, have them do their muscle energy technique, retest, feels better.
Better, yeah.
Bingo. Okay. And we're always, as PTs, trying to empower the patient to be able to do things for themselves. I don't want you to think that it's my manual therapy that's the key here. Like, my manual therapy is just helping me to diagnose the problem. I can use it for treatment, but it's really a means to an end. I really want you to be able to do this on your own. So we, come up with different techniques for a home exercise program to help the patient address those pelvic orientation issues. Now, I just talked about supine knee to chest, which isn't terribly functional. Right. When we do that in our life, but it does relate to standing on one leg and putting your pants on.
True.
So I think the thing that we forget is that we stay focused on the femur side and we don't stay focused on the pelvic side. We need to make sure we're looking at the interaction of the two.
Beautifully said. Beautifully said. And for those of you that are listening into this in audio, please check out the YouTube channel, because Carrie was using her hands a lot to explain some of the movements of the pelvis there. So you can watch the video to get a clearer understanding of
of what she was saying there. And Carrie, I think that is so beautifully said. And I think we're going to go ahead and end there because you and I are going to dive in deeper in the summit interview, and we're going to be talking about the core of the hip. So if everybody's wanting to learn more, please join us there. But I think you've made a very, very important point in this interview, is that when we're dealing with the hip, it's not just the femur. We need to be looking at the acetabulum and the
Yes.
orientation of the pelvis too, everybody.
Yes.
And if we're doing pelvic floor work, we need to be addressing the hip. So I think that is some really good food for thought for everybody. And I really appreciate you sharing that with us, Carrie. And did you have a gift or something that, oh, yes, from the it was Washington University. Tell us about that video that you were talking about.
Yes, I mean the kind of the evaluation for the movement system approach. The Washington University in St. Louis has a link to videos of the examination, both upper quarter and lower quarter, which is just a wonderful gift to everybody in terms of having that free information out there. So if you want to explore that more, we will be adding links to the show notes that point to the Washington University platform and all of the freebies that they provide to the PT population.
Awesome. Well, thank you so much for that. And everybody, please check that out if you want to learn more about how to evaluate the lower quarter with your patients. So thank you for that reminder, Carrie, or maybe that aha moment for some people that didn't realize the importance of both aspects of that hip joint. So thank you so much, everybody, for listening in. Thank you, Carrie, for sharing your wisdom with us today. And we will see everybody on the next episode. Thanks so much. Take care. Bye.
Bye.
Today's podcast was brought to you by the Institute for Birth Healing. To discover more, visit instituteforbirthhealing.com. To claim $50 off of any online course, use coupon code PODCAST50 at checkout. Till next time, I'm Lynn Schulte, founder of the Institute for Birth Healing.